Okay, so first off, I heard that you guys got a very nice curve on your first exam. I hope that most of you guys are pretty content with that, or what you got. If not, you kind of know where you need to work on. All of the exams from now on are basically just like that. The difficulty of the questions, how they're set up, and I think most of you guys saw that a lot of the questions come like straight from the study guide or sorry, the study questions or the quizzes that you guys took at the end of each chapter. They're basically the same, if not the exact same. So that's going to be how all of the rest of the exams are. um, except maybe the last one. I found that a little bit more difficulty, but not as not like that much more difficult. But for this exam, you guys already know, I think, that there is no erythrocyte and hemostasis. That's what I heard from you guys. The same thing happened in my class, so I'm guessing it'll be the same. Before we go through the checklist, just remember you really want to go through the study questions and quiz questions. Hopefully, you've already done that because those are the most important. And I'll emphasize this like every single review. That's going to be the most important for every single exam because she uses that to create the exam questions. And what I like to do is after I've gone through whatever I think, you know, suits my study style, I've gone through the study questions, the quiz questions. And then at the very end, I usually just like skim through the PowerPoint and like skim through and just make sure you understand or know all of the highlighted material because usually a lot of times a lot of questions will come on that. And I'm gonna be going through what I think is important, um, or things that you should just generally know, or I hope that you guys can understand better through this review, because it'll help you in your next, next couple of semesters and years to come. So not everything that's on the study questions is on this, so they don't completely overlap. So make sure you go through study questions. Um, you guys already saw in the first exam, at the very beginning, we kind of had just like basic background, right? Cellular injury, body fluid, um, how like all the metabolic things, how it works. Then you got into GI, and everything from GI onwards is just basically conditions. We're going to learn about a lot of different conditions and disease states. And what you need to learn now is how to organize a lot of this information because she's gonna or the slides are gonna overwhelm you with a lot of information. There's a lot of like symptoms, treatments. You don't need to know every single detail. The whole point of this course is to give you like an introduction to what these are so that you kind of recognize them in this future because they'll come up again. We're relearning this somewhat again in J2. You're gonna learn it again in S1. But if you already know it, that's a big plus because now I like for me, I don't have to study all this stuff again. A lot of people are still having difficulty because they didn't learn it properly or they forgot. So this goes for all of your classes. You want to be able to really identify what are they trying to get you to do out of this course. So this course is just an introduction. You want to know what the conditions are, um, and basically like what they generally are and what is a condition that's life threatening. Anything that will be like dangerous for the patient or things that are like very commonly seen, that's what you're mostly going to be tested on. um, and of course, even for all the other courses and like test questions and stuff, the whole point of nursing and like NCLEX is to test you what not to do. They're going to always test you like to make sure you know, what are the key signs and symptoms to make sure you know when someone is falling into like a really bad state and how to intervene, or make sure you don't do an intervention that's gonna kill them or harm them. So I encourage you guys to really use that mindset for not only this class but every single other class, because once you get into the other semesters, you're gonna have a lot more material and you really can't sit and study every single detail. You need to understand like what to pick and pull out of everything. So I'm gonna kind of go through some of the stuff and kind of help you guys understand what's important for each part. We'll start with alterations of pulmonary function. So there are different types of pulmonary disease. You know, there's acute, chronic, infectious, non-infectious. What they really usually test you on is obstructive versus restrictive, because this is a very testable question. The difference between them, obstructive is basically just they're true to its name, right? Something is obstructing your airway. So if you have like your air pipe or something, airway, something's obstructing. Usually, when you take a breath, your lungs expand, your diaphragm goes down, and there's like a negative pressure, and that automatically like pulls air in. So it goes in pretty normally, but there's like a slight obstruction. Your issue is when you have to like exhale and push that air out. When you're pushing that air out, it's really hard to get out because there's like extra pressure right here. So for obstructive, you have a lot of difficulty with I'm so bad at this. With exhaling. Obstructive, you really have a bad um like difficulty with exhaling. Restrictive is kind of the opposite. Anything restricting your lung movement, for example, conditions like fibrosis, if there's like a lot of scarring on your lungs and stuff, it's gonna get stiff and it's not gonna be able to expand as much. So if it's not expanding as much, you can't inhale as much anymore, right? You can't inhale as much. So obstructive is exhale, and then restrictive is inhale issues. And one way you could remember this is to think it out, logically through that, or you could also just remember um, restrictive has two eyes, so it's more about inhaling I. And sometimes I don't remember this chart coming up, but that could be like a possible like future NCLEX sort of thing. I don't think this was on our Patho exam, but just in case, if you guys don't understand this graph, this is basically what it is. It's just showing you how the volume of air in the lung. So when you're breathing, you breathe in and out. Breathe in and out. That's your normal volume of lung going in and out. Then when it shoots up like this is they usually do like breathing tests. So when you take a deep breath in, it goes all the way up, and then you hold your breath for a little bit, and then you exhale. And when they exhale, you exhale fully. So a lot of times when you exhale fully, you kind of like push past your normal limits, so it goes like a little bit lower, and that's normal, right? What happens in obstructive, remember, we're having issues exhaling out. So normal breath. When you try to really breathe in, there's a little bit of blockage, so it won't go as high, but you can still breathe in okay. Now the issue here is exhaling. Normally you can just exhale and shoot out all the air. But since there's an obstruction and you have to like push extra, we're gonna see like a long slope like this, not a sharp slope, but a very slow one like this. So that's obstructive. And restrictive, if that's the normal, again, we can't even breathe in that much because our lungs aren't able to expand that much. So it doesn't go very high. But the very little that it goes out, you can push it out pretty fine. It's just you can't breathe in extra. Um if any of you guys have ever have any questions or something, just feel free to speak up, or you can also just like type
Oh,
that in message.
so
Mm-hmm.
for restrictive disorders,
Mm-hmm.
would that include disorders like ARDS, acute respiratory distress syndrome, like decreased lung compliance, basically,
Depends on what is causing the arts, because like arts is kind of like a
or like a
general
group?
term. Yeah,
Oh, okay.
it's arts is just like an exacerbation. Just means
Oh, okay.
acute respiratory disorder, right? So something, whatever respiratory issue you have, now it's exacerbated and that's worse.
Oh,
That's
okay.
all it is. Yeah. Sometimes they have terms like that. It's very general. So it could be that. It really depends on the condition. But the example they usually use for restrictive is pulmonary fibrosis. They also talk about, I think, pneumoconiosis or silicosis. Anything where like you have inflammation or anything that stiffens the lung, basically. And obstructive, it'll be like a physical obstruction, like either like asthma, for example, that would be like obstructive because your airways are tightening, or um, sometimes, well, you learn it later, but bronchitis too. There's like a lot of mucus that blocks your airways too. Anything that blocks. And this okay, I'm pretty sure this doesn't come on the exam, but I'm just gonna teach this for you guys for later because this is really important for a lot of tests too. So obstructive is this one, right? Restrictive is this one. One way that they also like test the difference on this is something called FEV. And that's basically what they do when you go in. They make you like breathe in and then blow out as fast as possible. So FEV is like your forced expiratory volume in 1 second. And they see how fast, how much air can you breathe out in like 1 second. For obstructive, obviously, since it's harder to push out, that FEV1 normally, um, it'll be like this much. When you have obstructive disorder, that's going to go down because now you can't get out as much air in that one first first second, like from here to here, you can't get out as much. You'll only get to like this point, right? um Whereas for restrictive, FEV1 is the same. It's, you can breathe in and out fine. You guys don't have to know this, I'm just saying it. If hopefully some of you guys kind of like this sticks a little bit in your head for next semester and the semesters after that, that'll be great. But anyways, moving on. After this, we go into kind of a lot of vocabulary. You just kind of need to know the vocabulary. A lot of times you don't have to like memorize all the details, but just kind of know what these conditions are, so that if there's any question that's directly like, oh, somebody has like a bulbous fingernail, what would they probably have? They would have clubbing. And if you guys ever see that, by the way, that's probably going to be something you see in your health assessment too, that they're going to test on, because this is like, it's very it's very rounded like this. So this is a classic picture of clubbing, and whenever you see this, you immediately know they have a respiratory problem. Something's wrong with their lungs. So this is a clear indicator that they have like a lung condition. Um, for dyspnea, I'm just also going to point out these three like symptoms are some things that you should be able to recognize. They tend to say this a lot. Flaring nostrils. So if your nostrils are like going in and out, use of accessory muscles. That's basically mostly your neck muscles. So when you trying really hard to breathe, you're gonna see like your neck muscles being used, and like right above your clavicle is kind of be going in and out too. Um, and also retraction of intercostal spaces. If you're breathing really hard, if someone's having a really hard time between your ribs, like between your ribs, you're gonna see the skin actually go in when they're like trying to breathe. They're just like desperately sucking in like that hard if they're having, and those are um the main symptoms for anybody that is in respiratory distress. So if you have somebody like who has ARDS, like you mentioned, they could have that, or any other, like maybe they're having like asthma or some of the abnormal breathing conditions you see down here, Cosmal and Shane Stokes, you might see these symptoms. Um, down, breathing patterns, tachypnea, eupnea. Just know what that means. Cosmal and Shane Stokes, these are really important to know. Um, You just have to be able to recognize it in the sense that like the definition, because a lot of times they use these exact phrases: large tidal volume for Cosmo. So if this is normal breathing, tidal just means like how much lung capacity it is. So it's measured in and out, like I said, right? So Cosmo, you're taking big deep breaths in and out, big deep breaths in and out, and there's no pause. That's Cosmo. Shane Stokes is also called the death rattle, and you're gonna see that going faster, faster, or slower, and then you're gonna see this big pause, apnea. That is like a key sign of it, apnea. Breathing, 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 rapid, rapid, or faster, slower, and then apnea. Um, so make sure you guys recognize this. This will also probably come in your health assessment too. You need to be able to recognize graphs like this picture, and these exact terms: large tidal volume for them, and then Shane Stokes, um, like deeper or faster, and then stop. Um, I also put hypercapnia, hyperventilation. We already kind of went through that in the previous chapters, but it was also on the study guide, so I'll just make sure you guys know this the term really, because and make sure you don't get it confused, because hypoventilation, if you're not breathing as much, suppose you're like holding your breath, you're building up a lot of carbon dioxide, right? So that's hypercapnia. Versus if you breathe a lot, you're getting rid of all that carbon dioxide, so that would be hypo. So they're kind of like opposite. Less breathing, hypoventilation means hypercapnia, and then hyperventilation means hypocapnia. It's the opposite. Conditions caused by pulmonary disease. Let's see. It's good to understand hypoxemia. You don't have to memorize this, but just kind of keep in mind all the possible reasons that somebody might have low oxygen in their blood. It could be that they're not breathing properly, breathing less. There might be issues with their breathing. Maybe like if they have fibrosis or something, or any other condition where you're not able to perfuse the air. So you're getting in the oxygen, but it's not able to pass the lung into the bloodstream. We're going to learn later on about pulmonary right to, there should be L, sorry, right to left shunts. That's going to be in our children, where we have like mixed blood, and that's why there's less oxygen in it. Um, and even something as simple as this, being in a high altitude, there's just less oxygen. So decreased oxygen content in the air that you breathe. So just keep that in mind sometimes. You don't have to memorize it, but let's see. Pulmonary edema. We're going to go through this later when we get to heart failure, but all you need to do whenever you hear pulmonary edema, just kind of link it with left-sided heart failure, because a lot of the times it's caused by left-sided heart failure, because your heart is pumping, and then if it gets blocked, it backs up, it goes backwards, right? So usually the the oxygenated blood from your lungs goes into your left side. But if that left side is blocked, now you're going to have a backup into your lungs, and that's how you get pulmonary edema. Atelectasis. So this is something that they do test about often. I don't remember if they tested this on the exam. If they did, it might be about either compression or absorption. Compression is basically, okay, first off, atelectasis is like a collapse of the lung. A part of it collapses, like you can see that, or the whole thing collapses. Many ways that can happen, but the most common ways that we learn about is compression or absorption. Compression is basically if there's anything outside here, like right outside the lung, between the lung and the pleura that's outside of it, um, it's going to build up like blood. Um, if blood builds up there, that pressure is going to eventually cause um, the lung to collapse. Absorption is kind of the opposite. It's like from the inside. Suppose again we had like a blockage that like completely blocked off an area, then is it kind of builds like a negative pressure there, and then it's gonna like suck it in. That's why it's called absorption or resorption. It pulls the lung back in and it collapses. Um, this is probably like a low yield. Like I doubt this will come, but just in case. But what really comes often right here is post-operative atelectasis. A lot of times, people who have surgery will have lung collapse because they're not breathing properly, especially when they're like resting all the time and they're under a lot of drugs. Right? You learn like how a lot of them are vulnerable to respiratory depression. So, right here, these three things, this is what they test on. How can you prevent lung collapse? You do deep breathing exercises. We always want to teach our patients to deep breathe after surgery, change their position, and early ambulation. Early ambulation, I think that's what came on the exam last semester. But definitely know the three of those. And bronchiectasis, they might have tested on this picture. It's just like abnormal dilatation of the bronchi, and it's kind of intuitive, right? Saccular, it's like a sac. It becomes a balloon shape. Varicose means kind of like twisting and turning, so it's kind of like lumpy and all over the place. Cylindrical, it becomes like a straight thing. I wouldn't go further into that. Um, for pneumothorax, I put this mostly because this is another issue that comes in, and again, it's another thing about lung collapse. Um, so a lot of people get confused with pneumothorax and atelectasis. Both of them may have lung collapse. The only difference really is pneumothorax is air slash gas specifically. Atelectasis, it could be like fluid, it could be blood, like edema and stuff. But pneumothorax is specifically air or gas. Pneumo also means like lung, air, gas. So air, lung in your chest, basically. So there's two types: open and tension. Just to go through it real quick. Open is basically like if there's a little hole here in your lung, the air can like freely go in and out. That's it. Tension is if there's like a little hole or a rip like this, the air is gonna go out. But then when it tries to go back in, it pushes on those flaps, right? So now it's closed. So tension is like worse because now this air can't go back in because now these little flaps are closed and it keeps building and building, and that is what usually causes atelectasis or lung collapse too. Sorry, just lung collapse. Yeah. Types of pleural effusion. I would just kind of quickly read through like transudate is water, exudate it usually has protein. That's it. And empyema. Um, this is similar to this. Atelectasis had like blood, fluid, right? In the pleural area, pneumothorax had air. Empyema is just pus in that area. Going on to, let's see, pulmonary fibrosis. We talked about that before. Pulmonary fibrosis causes restrictive, and sometimes they use this phrase lung compliance. You know how much we can stretch, how much your lung is willing to comply to stretching. So that's all you need to know. Flail chest. I think this might have come up as a picture too. And we have a picture in the book. This is the one that they used, I believe. Flail chest is basically if you have a part of your ribs that's broken off. Normally, your ribs, when you're breathing, it'll go in and out, right? But if you have a section that's like completely broken off, it's gonna be stuck here. And when you breathe out, your chest is pushing out, but it's gonna be down here. So it's like it's moving in. And then when you exhale, when you exhale really hard, your chest kind of shrinks, right? But since that broken off piece of rib is not connected, now it's gonna look like it's moving out. So they kind of move like opposite to each other. Um, and That's all you need to know about that. It's just paradoxical movement and a fractured or broken off piece of rib. Pneumoconiosis, we did talk about this before. When you breathe in a lot of dust particles, that could cause inflammation, that could end up causing, scarring tissue and restrictive disorders. What you need to know about this is these three items: silica, asbestos, and coal. This is tested a lot to see if you know pneumoconiosis specifically, because these are kind of like very specific scenarios, right? So if you ever get a question about somebody who's like in construction work, because way back then they used to use like asbestos for like insulation or something, I think. Maybe they still use it. I'm not sure. I doubt it. But construction or coal miners, especially coal miners, um, they're never gonna ever give you a question about coal miners unless it's probably something related to pneumoconiosis. So if you ever have like a case where you have a coal miner come in and he has breathing problems, he has pneumoconiosis. Um, Arts. We already kind of went through arts. Perfect. Yeah, ours is just an you have a respiratory condition and then it exacerbates suddenly. All you can do here, treatment, is really just support whatever they have, um, try to treat whatever they have and prevent it getting worse. Most common post-op problems. We already went through this kind of with atelectasis, but other common post-op problems are pneumonia, pulmonary edema, and emboli, because again you're like kind of like stagnant all the time. You're not breathing properly, so it's easy for you to get an embolus or edema, or also infection from like maybe aspiration or just sitting there. um, you just need to know prevention again, and it's the same thing: ambulate, turn, and breathe. um, okay, obstructive pulmonary disease. um, this is something that people do tend to confuse. uh, Obstructive, again, remember they're having difficulty breathing out because something is blocking. So you're trying to push out past the blockage. COPD. COPD is kind of like a big umbrella term, actually. Um, a lot of people just use it, but it actually includes chronic bronchitis and emphysema. Both of those count as COPD. Or it could be like one or the other, but they're both included in COPD. For um, chronic bronchitis, what you need to know is that this is the requirements for diagnosis: 3 months of the year for 2 years. So if somebody's been coughing a lot for like 3 months or like a couple months, that you can't count them as chronic bronchitis. It has to be 3 months for of 1 year for 2 years. Um, Another thing you want to know about chronic bronchitis is this term right here, blue bloater. And what happens is that because they have a lot of inflammation and blockage, they can't breathe out, so they're having difficulty breathing out all the time. They're just not getting out enough of that CO2 out. A lot of them start to get cyanotic, so they're called blue bloaters. And a lot of people with this condition also tend to have like edema and stuff. That's why they're called bloaters. One thing you do want to keep in mind about people who have COPD in general, or any of these like lung conditions, especially COPD, is that because they're excuse me, because they've been having this issue for such a long time, um, they're not gonna have like the normal amount of oxygen that most people do. Like for most people, you want to keep them above at least 90, right? At least. Um, but for a lot of COPD patients, they're having them in the like low 80s is, oh sorry, the high 80s is ideal. If you push them into that 90s, you're actually gonna worsen their condition. So that's something you'll learn more about later too. But the second type of COPD is emphysema. And emphysema, you need to know this phrase: alveolar wall destruction. Um, So when you go in down to your alveoli, they're all like this, right? So these walls break. Um, I would also kind of keep in mind this might come up or might not. If it doesn't come up on this exam, it would definitely be something testable on the NCLEX. Deficiency of alpha antitrypsin. And what happens is that there's a lot of like proteolytic enzymes that basically break down protein, and this usually blocks that from happening in your alveoli. But if somebody does not have this, those enzymes are going to come and they're going to eat up the walls of your alveoli, and now your alveoli looks like this like smooth little ball right here. What that does is, first of all, see, now you have less surface area. Um, and before, each of these little sections kind of like push the air out, but now you have like a whole bigger mass of air to like push out. So a lot of times, a lot of air just gets like stuck here because now you don't really have the contraction ability to like push things out anymore. So because there's like air that gets stuck here, we call these people pink puffers because they're really trying to push out as much air as they can, and that they're like puffing, and they usually try to like breathe a lot, so they become like pink because of that. Um, so you don't confuse them. Just remember, blue bloater has B in it for chronic bronchitis, and then pink puffer is emphysema P, because they kind of test that too, whether you know which one is associated with which, pink puffer, blue bloater. Asthma, definitely want to know all of this part. Know the different types of asthma, intrinsic versus extrinsic. Intrinsic is just, you just normally have it, no cause, no cause, literally. Just, that's all you need to memorize. Don't need to memorize the rest of this. No cause, intrinsic, extrinsic, outside environment. And you need to know type 1 versus type 2. So memorize this parts. Just kind of know what status asthmaticus is. Uh, that just means that if you have asthma that's exacerbated again, it's so bad that your usual measures of kind of treating it, whatever medication you use, or just breathing slowly, whatever it is not working. That's that's just status asthmaticus. Respiratory tract infections. Most common cause of short-term disability in U.S. Anything most common, I would always just keep it in mind. Um, Next, for pneumonias, types of pneumonia. So in your slides, it was kind of written differently. You had community acquired, nosocomial. This is actually called hospital acquired, and then for some reason you guys have Legionella. But the third type is supposed to be aspiration. Legionella is just like a bacteria that's usually found on like ships or something, or like water sources. So a lot of times you're gonna hear people who go on like cruise ships, or maybe like they're in the navy or something. There's like a Legionella outbreak. Um, but community acquired, that's obtained outside normal life. Hospital acquired, true to its name, in the hospital. And then aspiration, if you're accidentally like aspirate something, right? Um, the stages of infection in pneumococcal pneumonia. Um, I distinctly remember this coming on the exam, especially something about red hepatization or gray hepatization, one of these. So I would just kind of know the stages and like the sequence. Sequence. Tuberculosis. Tuberculosis. Just again, just kind of know what tuberculosis is. It's by M. tuberculi. Um, Common symptoms. Oh, you kind of want to know the pathophysiology. What kind of, you can just kind of read through it. It's very simple, but uh, common symptoms, a lot of times it's asymptomatic until it becomes really bad, but common symptoms that they kind of describe tuberculosis with is night sweats right here. Night sweats, weight loss, fever. So if you ever hear those three, that kind of, especially night sweats, that kind of like indicates possibly tuberculosis. It could be, yeah, weight loss and night sweats can also be like other things, like even cancer or like a lot of other conditions. But a lot of times it also could indicate possible tuberculosis. For evaluation, I think in all of this, there's like three different types of staging gradings that you guys learn. I think at least like one of them came, but I don't remember which. So I would just kind of memorize them if you can, or just get a general idea. What I remembered for tuberculosis is kind of it's sequential, right? You start at zero, you have nothing, no TB, no exposure, no infection. You pump it up to one, they have exposure, no infection. Now two, they have infection, but no disease because it's latent. Three, they have infection, but now they do have a disease. Four, they have infection again, but no disease because it's treated or it just went inactive again. And then five is like suspected. Just remember. PE and pulmonary hypertension. Pulmonary embolism, I think we talk about that again kind of a little bit later. This is important because it's very dangerous. So this is something that could potentially like kill a person. A lot of times it's because somebody has right here DVT, deep vein thrombosis, so they'll have like a clot or something in their legs, and a lot of time if they're like resting a lot, bed rests, again post-op patients, or somebody like this happens also in people who like fly long flights on an airplane. Um, you could that clot could accidentally dislodge and come back all the way to your lungs and um, could potentially lead to death. So just keep, you know what it is. Um, Pulmonary hypertension is just high blood pressure in your arteries. Um, I would kind of know this range. I don't remember if that came or not. But one thing you need to know for sure is core pulmonale. This is pulmonary heart disease. A lot of people test this because um, it sounds like other conditions, but just know core usually means like heart, pulma, mon is like lung related. So um, heart disease that's related to the lung. So a lot of times pulmonary hypertension causes um, hypertrophy of the heart because of that blockage or too much pressure. So then it backs up to the heart again, and then that's how you get core pulmonale. Cancers of the respiratory system. Um, I really feel like one of these came. Um, so I try to organize it a little differently than in the PowerPoints because for me, it was really confusing in the PowerPoints. But you really do not need to know all these like extra details. Just kind of know their names, and I think maybe like which one are more popular. Like maybe adenocarcinoma is 30 to 35%, or um, large cell is like undifferentiated, something like that, or oat cell carcinoma. Just kind of like know them very generally.
Wait, I
Um,
thought Grigsby told us not to memorize the cancers. Or
if
like,
she did, then go with that.
oh, okay, okay, okay.
Okay. Yeah. I don't know what's coming on you guys' exam. I doubt she changed it, but I feel like I remember there was like one question, but it's if at the most it's just one question. And it was probably like very general. But what you do know, always remember, lung cancer, most frequent cause of cancer death in U.S. and it's more common in women, stuff like that. I think I remember this also coming in. Just the TNM staging, all you need to know is what it is. So, uh, tumor, nodal, metastasis. That's how they grade how bad a cancer is. Like, how big is the tumor? How much of the nodes, the external nodes, is it like involved? And then how much has it spread? Um, so just know what T, N, and M stand for. And that's about it for pulmonary. I'll move straight on to cardiac. Cardiac structures. Um, This is basically just going through all the congenital defects, and honestly, you kind of like need to know all of them, but um, most of them are very general, and they kind of all have like the same symptoms and stuff. I would know murmurs. Just go through these grades again. But what you need to know is anything louder than 3 is pathological. So, just like with the tuberculosis, it's sequential, right? Grade 1, you barely hear anything. It's not 0, you can't hear nothing. You can't hear absolutely nothing. So it's grade 1, starts at grade 1, barely audible. Then 2 is a little louder, 3 is a little louder. Um, 4 is when you start feeling a thrill. And if you can feel that, then that's dangerous. 5, you can hear the thrill and the murmur and kind of hear it even if the stethoscope's not on the chest fully. And then 6, that is so bad you don't even need a stethoscope to hear it. But it's also, note this right here. In the first few hours of a newborn life, it's actually very common to hear murmurs, just for a newborn though. All right, I'm gonna go through adrenal ASD. Oh yeah, atrial septal defect, ventricular septal defect. Okay, I will go through a quick review of fetal circulation with you guys. I do this. Maybe this one? So, the baby, right? The baby usually gets most of its blood and nutrition, like its oxygen, from the mother. So a lot of that is going to come from here, the umbilical arteries and veins here. The veins bring it back over here, and it comes up into the heart. Um, Something that's special about the fetus is that they don't use their lungs, right? They don't need their lungs for breathing because we're getting all the oxygen from the mom. So because of that, usually, it kind of goes through and then goes through the lungs. That doesn't happen. What happens instead, right here, you have foramen ovale, this kind of like a little window right in between the right and left atrium, and some of the blood kind of like pushes through here. So you always have like mixed blood, and you have that in like a couple different places. You have foramen ovale, you have ductus venosus here, and then ductus arteriosus. So there's like 3 locations where it's not supposed to be connected, and we don't have that in adults, but because of that, we can have like a mixture of blood, of oxygenated and deoxygenated blood, to kind of get oxygen faster around because they don't have their lungs. That's just like a short rundown. But what happens in a lot of these septal defects, what happens when they're actually born, is all of those little pathways close. So especially this foramen ovale, all of them will close. And normally, because like blood is like pumping up here, and that's like the strongest force, right? You're getting most of the blood flow from the mom up here, and it's gonna pump. That's what usually is called right to left shunt. You have this little window, it goes from the right side to the left side, right to left shunt. um, Simply because the force is stronger. So once that closes, your circulation is going to be like normal again. The right goes to the lungs, then it comes back to the left side, and they're separate because this should close. If you ever have a defect anywhere, either here in the atrium or like in the ventricles or something, what happens, because now you have more pressure on the left side of your body, right? Once you're born, now your left side is stronger because now it has to pump through the whole entire body. So since the left side has more pressure now, um, and we have a hole that's not supposed to be there, now this blood that's supposed to go down through the heart and out to the body is actually getting pushed back into the right side. So that is called left to right shunt. Um, and that's where you get all of most of these congenital like defect issues because they're supposed to be getting blood normally, but because they have like some sort of defect, things haven't closed properly once they're actually born. The high pressure of the left side is going to push the oxygenated blood to the deoxygenated side. So now they're not getting as much oxygenation. So a lot of them can become like cyanotic even. Um, so atrial septal is just it's gonna you're gonna have like a hole or issue with the atrial septal wall. Septal is like in between, right? So the atrial walls. Ventricular is on the ventricular side. I would know this condition, Eisenmenger. It just means that sometimes um, these kids have like a small defect, and you won't really notice that it's really bad because there's just like a small amount of mixture happening. You're still getting blood, but over time, as you get older too, it gets worse and worse, and then they're gonna get cyanosis after years instead of like immediately. Um, Patent ductus arteriosus. Um, that just basically means all of these things. Ductus arteriosus is still there. It was supposed to close, it didn't close. So we have patent ductus arteriosus, you have patent ductus venosus, or you could have patent foramen ovale too. You could have any of those. Um, yeah, let's see. Eisenmenger, PDA. Normally, what happens is when they close, they completely close off, and since there's no blood like going through them again, they kind of just like shrink and shrivel up, and they become like kind of like a ligament, because they're just like practically like a string now. So after they're closed, ductus arteriosus becomes ligamentum arteriosum. Same with venosus, ligamentum venosum, etc. Okay, that one's just like general. This one you really need to know tetralogy of Fallot. Um, this is like a big one that a lot of people test on. So tetralogy of Fallot is like very unique. Uh, One, because it's the most common cause of cyanotic heart disease. Two, because you kind of have to have four major defects. One, pulmonary stenosis. That means you're gonna have like difficulty uh, with your pulmonary valve, like it's kind of stiff. Two, their right heart is hypertrophied. Three, overriding aorta right here. If you can see this, I don't know if you guys can see this picture correctly, but basically, overriding aorta, what happens here is normally this is your right heart, right? It kind of like goes like this. Um, and then this is your left heart, and it kind of goes like this. The atrium, ventricle, atrium, ventricle, and then it goes out this way, it goes out this way. What happens here? Both of these vessels are combined. There's no separation. That's called an overriding aorta. So now, instead of them being separated, the blood immediately mixes. And to make matters worse, they have a ventricular septal defect. So a lot of times it's open right here too, because that's kind of what happened, right? This wall in between completely didn't form. Um, so now there's like kind of like a hole in the ventricular area, and they all go together in a single vessel. So you get major mixing of blood. So they're not getting like fresh oxygenated blood now; they're getting like a mix. Um, yeah. Okay. It's probably a coarctation of the aorta. Um, you can just read through most of these. The other one, coarctation of the aorta. Um, I just wanted to go through it in case you know. Sometimes people don't know what that is. Coarctation of the aorta, if you look at it, it's literally like this. This is your normal aorta. This is coarctation. For some reason, it's just like constricted. So because of that, you get a lot less blood going through, and it's also like high pressure here, right? So all of these like conditions, it's basically showing like I said before, they're just not getting enough oxygen. So you want to think about how that's going to affect the baby, um, baby survivability, especially. Hypoplastic left heart syndrome. Hypoplastic means just like the left side is not as strong. Um, I I really don't remember if there was a question on this or not. Um, I feel like there was, but I'm not sure because I just remember studying it. Um, but I put like a very basic summary of what they are. Just first stage is Norwood, second stage is bidirectional, third stage is Fontan. Just know the first one. Just read it. Just if you don't want to, that's fine too. It'll probably just be one question max, but it might not come either. Stenosis, if you guys know, um, that's like I said, the valve gets like stiffened or hardened, so it's like narrow, so it's difficult for the blood to pass. Of course, that will also affect the child again because they're not getting enough oxygen, not getting enough blood. Transposition of the great arteries. This is a also another important condition, because like if you have this, the baby is just 100% not gonna die, survive. What happens, as we saw before, you have your right atria, right ventricle, and then it goes out. Um, and then left atrium, left ventricle, and then it goes out. That's kind of like my ugly way of drawing a heart. What happens here? Normally, this goes to the body, and then this goes to the lungs. Um, for some reason, they swap directions. So you get this deoxygenated blood. It goes to the body, it comes back from the body, and it comes back to the right heart, and then it goes out to the body, back to the heart again. So it never ever goes to the lung. Meanwhile, on the left side, you get oxygen from the lungs. Oxygenated blood from the lungs comes out and goes straight back to the lungs. Um, so because of that, you have two closed circulations going on, right? So the baby is essentially never gonna get oxygenated blood because you're only passing around deoxygenated. So you have to have surgery for this, but survivability is 90%. Um, Tapper total I don't remember if this came or not, but I'm not gonna go through that. You can just read it. Congenital, non-congenital structural heart defects. So all of those typically are just like malformation during like the development of the child, right? Um, all of these conditions now, the non-congenital ones happen outside. A lot of times it's because of like bacteria. For example, rheumatic heart disease. You just need to know that that's associated with group A beta hemolytic streptococcus. A lot of times when they get like a infection with this, then it's very common for them to get rheumatic heart disease. Same thing with endocarditis also. Um, a lot of times bacteria goes and colonizes on the valves, and then they like damage it. um I would know these three kind of manifestations. I wrote out the pathophysiology. Basically, the bacteria somehow manages to go to your heart. You know your immune system attacks it and like covers it, but then that little like ball of like fight back breaks off, and then that microemboli goes somewhere else and causes like little hemorrhages or petechia. So if they end up going all the way to your fingers or your toes, those are called osler. um Janeway is like purple lesions, and they're small. And the difference is this is non-painful. Osler was painful, and Roth spots are seen if they go all the way to your retina. A lot of times your vessels are like red, right, in your retina when you look at the picture. But since there's like a blockage now, you're not getting blood there, so you'll see white spots. And that's it. now go through shock and heart failure. I combine them into one because shock is it's pretty short. Shock, you need to know that it's life threatening. Um, you might need to know the stages of shock. Just compensatory, it just means your body's trying to make up for all the deficits that you're having. You're not getting enough oxygen. You're not getting enough blood perfusion. Um, Progressive, now it's progressed. Now you can't compensate anymore. So if this continues, it will lead to possibly death. Types of cardiogenic types of shock. You need to know all the different types of this. Cardiogenic, that means it's because of your heart. Your heart has issues. Some cardiac condition. Obstructive, something is blocking again. So we talked about, like, for example, we talked about pneumothorax. So if you have like a lot of air or fluid or anything in your lungs, um, if it's like a lot, it's gonna put pressure on your heart, um, and because of that, now your heart can't expand anymore like as much. So that's gonna cause obstructive shock, hypovolemic shock. You lost a lot of blood through dehydration, hemorrhage, burns, so you don't have enough blood. Distributive, there's three types. Neurogenic, that means because of you know, your CNS system. I would remember it comes from the medulla area. Anaphylactic, I already know that, and septic shock. That's I hopefully everybody's familiar with septic shock. Um, just like just generally know it. DIC and mods. I would just know what these are. DIC, disseminated intravascular coagulation. Sound all of these, like, they sound complicated, but they're pretty simple. It's just like um, when you're in shock, your body is kind of going crazy, right? So um, your inflammatory cells, your immune system, everything's doing whatever it can to protect your body from dying. So because of that, it activates like a lot of different systems. For example, your clotting. So um, now your body is just gonna have like a lot of clotting that happens everywhere, and you don't want that. You don't want it to be out of control and nonstop, and that's disseminated intravascular coagulation. The other one, mods, which is multiple organ dysfunction. That's it. If it gets so bad, your organs are gonna start getting bad. Heart failure, you should already know this, but just know these equations. Cardiac output is dependent on stroke volume times heart rate. So how much your blood is pumping out and how fast it's pumping out. I would also kind of understand how your body compensates. So RAS and your sympathetic nervous system. Um, I think your study questions kind of goes through more in detail of this a little bit, and you don't need to know a lot. You just need to be familiar with it and like how does it help? How does it help? The stagings, I would just remember them just to be safe. I don't think these ones came, but I had studied them just to be safe. Depends how much you care about your grade or not. Heart failure staging. Okay, left sided versus right sided. This is very important to understand because this is tested a lot. You need to be able to identify as a nurse if they're having heart failure. What's the root cause? Is it from the left heart or the right of the heart? And it's pretty simple. But as I said, if there's issues with the left heart, then it's gonna go backwards. It's gonna go backwards into the lungs. So you're gonna have all these symptoms. They put all of these here, and yeah, you could have any of these too. But the main ones that they usually test off is, you know, lung issues. So they'll have shortness of breath. They'll have pulmonary edema. That one's huge. And occasionally they might say they'll also have frothy blood tinged sputum. Meanwhile, the right side, if you have a backup on the right side, Remember, your blood is coming from your body and it's coming back up to your heart. But if there's so much pressure or like there's a backup on your right side, now all this blood that's trying to come back from your heart, it can't go there. So it's going to get stuck in your body. And because of gravity and a lot of things, mostly it goes down to the feet. So right heart, you're going to see peripheral edema right here. That as soon as you see peripheral edema, that's a big indicator that's probably right heart. Another thing is jugular vein distension because you have, the IVC, the superior vena cava, and the inferior. So you have the inferior side, it's getting backed up, so you'll see the peripheral edema. The superior side is also getting backed up, so you're going to see jugular vein distension. You're also going to see liver enlargement because if you guys remember, the liver kind of has a different circulation that tries to come back to the heart. That gets blocked up, so now your liver gets all blocked up, and you're going to see liver enlargement and ascites. So um, and you definitely need to remember, just like memorize this and repeat it like a mantra. The most common cause of right sided heart failure is left sided heart failure because the left side is the stronger heart, right? It usually has a lot of more muscle. So if that goes wrong, that backs up into the lungs, which then backs up into the right side. It kind of goes like that. Different types. So that was one way of classifying between heart failure. You could classify heart failure as left-sided or right-sided. Another way that they do teach is systolic versus diastolic. Um, some background knowledge I wrote in. Um, the way they kind of like measure how well a heart is pumping is for stroke volume, how much blood is being pushed up. And the other one is called ejection fraction. So that means the amount of blood that like initially went into the ventricle. Are we pushing most of that out, or like you never push out like everything, but are you pushing out almost 100 of that, or is a lot of blood getting left behind? So that's how you test how well your heart is working. So there's two types: systolic versus diastolic. They're also referred to as this. Systolic will be heart failure with reduced ejection fraction. It's kind of summarized like this: H heart failure, R reduced ejection fraction, or diastolic preserved ejection fraction, PEF. You're gonna learn about this more if you haven't already. You might have already learned this in farm, but um, they might have like case scenarios where they kind of mention this in farm for cardiac things. Um, but this is basically the difference, right? Um, Reduced ejection fraction. Why are they not able to pump out as much as they need to? This happens because the muscle's just weak. So systolic is the contraction, right? So that's why we call it systolic heart failure. So because that contraction is weak, it's not pumping out as much as it can or it should. So that's also called reduced ejection fraction. Diastolic, remember, that's the filling area. So what happens in diastolic heart failure, you're gonna see like a lot of times when somebody's having like hypertension or any other issues, heart issues, your heart starts to hypertrophy like this. Or if you have like some condition that causes scarring, now your wall is so thick it can't relax properly and let in more blood. So you're just not getting enough blood in. So technically, your ejection fraction is preserved um, because you're just getting less blood in, but you're also able to pump that same amount out. There's no issue with pumping. So that's why it's called preserved ejection fraction. Meanwhile, systolic, you can get more in, but your muscle is not strong enough to push it out. So that's systolic. And lastly,
Wait, for diastolic, so like
mhm,
because the muscle is too like thick, there's less blood
mhm,
in the. Okay.
right, yeah, you're just able to not able to get enough blood inside, like fill the ventricle up. Yeah, so that's why um you'll have heart failure because you're just not getting enough blood out because you're not pumping. You're only pumping out a little bit of blood. Meanwhile, systolic, it's heart failure because you're able to pump, but you're only able to pump very less because your muscle is weak, right? They're kind of the same in different ways. The last sort of categorization, this one is very unpopular um, way of like categorizing them, but I'll just go through it. High output versus low output. Low output is your usual type of heart failure we usually hear about, like kind of like this. Somebody has like just has a weak heart. Their heart is not able to either for either of these reasons could be a potential reason, but they're not able to pump out enough blood naturally. Um, High output heart failure is different because their heart is working totally fine. It's pumping normally, but you have some sort of condition. A common one here is thyrotoxicosis, where you have a lot of all of these conditions. Really, it's like a lot of hormonal conditions or like metabolic issues. Um, Paget's disease of the bone is also like cancer. A lot of things. Your body is using up a lot of nutrients and materials, um, and it has like a high oxygen demand. But your heart, you're not able to get out enough nutrients and oxygens to meet up that demand. That's simply it. Like your heart is fine. It's just you have some sort of disease that is so strong. It needs more. It needs even more than what your heart is able to give. And acute decompensated heart failure. I would just be familiar with this term. You don't need to know anything about it more than I think Dr. Ayala liked to use this term a lot too. But it's basically heart failure, but acute decompensated means decompensation, right? Like it's not there's no compensation happening. So somebody has an exacerbation of heart failure. This is really bad. So if somebody comes in with this acute decompensated heart failure, you want to work on them stat. Like you need to make sure um, you get all of their everything like stable. Okay, coronary circulation. Know that cardiovascular disease is leading cause of death. That's about it. We already kind of went through atherosclerosis before, I think, but if you guys don't remember it, it's just you have like plaque that builds up on your vessel walls. It can be because of like hypertension or if you like have bad diet or a bad lifestyle. A lot of times, all of these like heart disorders, a lot of times they have the same risk factors and kind of like treatment. So I kind of like pile them here, and you just kind of need to know them generally. Um, Risk factors: high blood pressure, of course, high cholesterol, smoking, tobacco, big one, diabetes. Diabetes is usually a risk for like just about everything. So you can put it on the list whenever you get a chance. Family history, of course, and race and ethnicity. You need to know that cardiovascular disease is a lot more common in African Americans. Um, Generally, no coronary arteries. Okay, so coronary artery disease, it's part of cardiovascular disease, right? Cardiovascular disease is just like an overall blanket term. So coronary artery disease is specific to the coronary arteries, which are the vessels that actually give blood to your heart. So your heart is giving blood to your heart. Um, I would just kind of know them generally. Let me show you coronary arteries because I think there might have been one question on identifying them. Coronary arteries. Maybe this is a good one. This is usually how it is. You have the right heart here, the left heart. You have this long branch going down, and this is kind of this supplies like most of your heart. Your left side kind of like overpowers the right side. So you have the left main coronary artery and the right main that start up here near the base of the aorta. Um, I wouldn't really remember these. They don't really, I mean, left, right main coronary artery. It's not hard to remember. But these one down here, you have one going down here, and if you flip to the back of the heart, there's actually one going straight down the middle, down the back too. This one is called the left anterior because it's like right in front, descending because it's going down, left anterior descending branch, and it kind of goes down the whole heart and supplies a lot of like this in both sides and the interventricular area, both ventricles and the left heart. So sometimes they shorten that to LAD, lad, um, lad, or they call it anterior interventricular because it's kind of like right down the middle, right of the ventricles. So I would know that circumflex, um, I think circumference, it kind of goes like around, it kind of goes around this heart. That's the left circumflex. But I would really remember the left anterior descending branch. A lot of times people who have like MIs and stuff that are like really dangerous, it's usually like here or like in the back one. Um, for the right side, you have, it's a smaller one. You have the right marginal branch because it kind of goes off in the margin. And then you have that same one. This one was the anterior descending branch. In the back, the right side is the right descending. The posterior. The front one was the anterior. The back one is the posterior. And you can kind of read what they supply. I wouldn't memorize any of it, but just kind of be familiar with these terms. That's what. For coronary artery disease, this is also like there's a lot of many different types of coronary artery disease. One of the things that could happen in coronary artery disease, you have angina pectoris. This is basically actually the definition is really just chest pain, right? Angina means pain, pectoris, that's your pecs, that's your chest. So chest pain. When somebody has chest pain, there's two types: stable or unstable. And you need to know the difference between this. It's very simple. The only difference is that stable, when you rest, it gets better. You feel better. So you become stabilized. Unstable, even though you rest, you're still feeling that pain. That's all the difference you need to know. Um, Myocardial infarction. We already kind of went through that, I think, before, but you could have tissue death in your heart. Diagnosis of, right. So treatment for coronary artery disease, as I said before, a lot of this goes for any like cardiac condition. So you don't have to make it exclusive to um, CAD. Um, and just, I would never memorize all these symptoms and stuff. Just kind of like know it generally. So a lot of these people who have hypertension, like high cholesterol, the number one thing, if you ever have this in a test question, the number one thing you always want to do like lifestyle modifications first. So diet changes, weight control. You never go to medicine. Medicine will be like your last step. If they were smoking, you want to stop them from smoking because that was a risk factor. And then you go into hypertension control. The most important one you need to know for that is statins. And I feel like I remember something this from the exam. I'm not sure, but I just put it here. Again, I wouldn't memorize, but just know that statins are recommended for kind of like these ranges. Okay, acute coronary syndrome. Acute coronary syndromes are like any CAD, any coronary artery disease But if you have it suddenly, that's the only difference. Um, a lot of terminology. You don't really have to worry about all this. Just if you kind of know the conditions, that's fine. Um, I wouldn't worry about this one. This used to be called unstable angina, but what they always test you on is NSTEMI or STEMI. ST elevation, myocardial infarction, or non ST. And let's see. Yeah, I can see this. Um, this is your normal like ECG, right? So the reason they're called that is because in STEMI, um, this is your ST segment from here to here. It's elevated. That's it. And STEMI, it's not elevated. That's the only difference. Um, you'll learn how to read EKGs and stuff though later. But for both of these, you need to know that how to diagnose them having this is you look for cardiac markers first, troponin and CKMB. Those are your ones you want to remember. All of this stuff you don't really need to care about as much, especially myoglobin. That's just like breakage of your muscle cells, but that doesn't have to be exclusive to the heart. That could be like, you know, any other muscle in your body too. So that's a little outdated. Um, you want to kind of know about how to treat if they have any of these myocardial infarctions. Um, if you guys remember, we talked about reperfusion a long time ago, and we can have reperfusion injuries. So basically, we want to unblock whatever's causing that infarction and bring back blood into that. But sometimes that can cause injury. There are two main methods: PCI and CABG. I don't know if they call it cabbage or not, but I call it cabbage. But PCI, I put a picture here. It's very simple, but what they do is they put a catheter in. There's a balloon with a stent on top, and then once they find it in that area that has like a blockage or like a plaque or something, they're gonna expand that balloon and squish it. Then that's gonna keep that stent in place, and they're gonna take out the balloon, and now the stent is keeping that artery open and making sure that it's not blocked. That's it. Coronary artery bypass grafts. What happens is that blockage, what they do is they take another blood vessel. A lot of times it's like your chest, you have like a thoracic, I think, artery that like goes down your chest and it's pretty long. So a lot of times they take that or something from your leg and they attach it to before the blockage and after the blockage. So now instead of your blood going through that blocked area, it's just going to go through that extra um, little artery. So just kind of know that that's what they do. And whenever you do any of these conditions, you want to use antiplatelet so there's not clotting happening again. Um, you guys might be familiar with this, but I would just at least know clopidogrel. You'll learn that in farm too. Complications. Okay, complications of acute coronary syndromes. All of these are a lot of different types of heart issues. I probably wouldn't memorize any of them. You can just read through them if you want to kind of like have the names in your head. But all you need to know, I would say, is atrial fibrillation. That's the most common dysrhythmia. A lot of times it leads to pooling and clotting. Atrial fibrillation, if you don't know, it's kind of like your atrium just like goes really, really, really fast, right? Um, and this is like very common cause of stroke as well. And let's see. I would know pericarditis. That's just kind of like how the lung had the pleura. There's also like a covering or a bag that covers the heart, and sometimes that can get inflamed. And all of these are like after you have an MI, how can it affect you? You could have all of these extra dysrhythmias, or you could have inflammation of the heart sac. You have something called Dressler syndrome. You should know that because that's basically pericarditis, but for some reason it happens much later, like maybe even years later. And then cardiac tamponade, you need to know that because that is a life-threatening condition. Um, so if there's like inflammation or anything, a lot of times there's blood or fluid buildup after an MI, and that's gonna fill up that sac. Um, Let me show a picture of it. This is a good picture of it because it's basically this is the pericardium, and because of that MI, you have either like inflammation or fluid buildup because so much happened, and now you have all this extra fluid in between that sac covering and the heart. And what that's going to do is it's going to squeeze your heart again, and that's very dangerous. And one indicator of this is called pulsus paradoxus. Um, you're going to see an abnormal decrease of more than 10 when you're breathing, because when you're breathing you're putting more pressure on your lung, and then that's going to put pressure on your heart because you're filling your lungs with air, right? So now there's even less space for your heart, and now you have all this fluid around your heart. It's pressing. Valvular disorders. I just wanted to go through the differences between the different the valve diseases. In case you guys don't know it, there's stenosis, regurgitation, and prolapse. Um, if you have your heart valves, like if you have your heart valves, like um, stenosis is basically they become stiff like a stone. So it could be because of like bacteria, or sometimes there's like calcification, so it gets stiff. Regurgitation, um, your valves just kind of become loose, so or sometimes they don't like close properly. Um, so what happens is that blood comes in, but maybe it's not closed properly or something. This also happens in um, stenosis too if it's not closed properly, and then it'll come back. So you're regurgitating it out. It's coming out, and then it's coming back in. And prolapse is when the valves are completely like going into the wrong the wrong heart area. Prolapse, or you can like collapse. Rheumatic fever, we already went through that. Remember, rheumatic fever, they could have post group B post streptococcal bacteria. I believe that was it. Um, so associated with like a bacteria, and a lot of times I would remember these three: chordae tendineae rupture, papillary muscle, and mitral annulus. Your chordae tendineae, they kind of like, that's what you call the heartstrings of your heart, right? So if you have bacterial infection, that could break apart your papillary muscles. Also could get affected, and all of this will lead to your, because those are what control um the valves. Basically, that's what helps it open and close, these cords and the muscles. So if any of those get issues, you're gonna have either regurgitation or stenosis. Mitral annulus is just like the cusp, the valve itself. And TTE, I just highlighted it. I don't remember it at all on the exam though. Let me close all these. Okay, now we are on. Oh, did I not write one for vascular disorders? Huh. Okay, well, we can go through it. Last one, vascular disorders. Um, what you kind of need to know is you can have two different types of peripheral vascular disorders. So peripheral means anything that's not the brain or the heart. And just be careful because on the slides they were kind of getting it mixed up a bit and kept mentioning brain and heart. This PowerPoint I remember was like especially jumbled up. But yeah, you could either have peripheral artery diseases or peripheral chronic diseases. Oh, sorry, peripheral venous diseases. So either artery or venous. Um, and a lot of times later on, you're gonna want to be able to differentiate between, like, for example, like a venous ulcer versus arterial ulcer. I'll kind of go through that down here. But one thing you need to know: ankle brachial index. You compare the BP in your arms with the BP in your ankles, and a lot of times that can indicate if there's like a big difference. Um, if there's like a big difference, I think it showed like, oh, you might have to look it up, but I think it was like a difference of more than three, or I'm not sure if that's just an infant's. But if there's like a big difference between the blood pressure in the arms and the ankles, that means you're not getting blood to, like, for example, your ankles. Usually the ankles is lower because it's further out. So you could have like a issue with circulation, like artery disease. Um, for venous things, a lot of times what you're gonna see is swelling in your legs or discoloration down there because what happens with venous, right, is supposed to bring the blood back up. But if you're having an issue with the veins or the vein valves, it's gonna the blood is gonna pull back down there. Um, and you just kind of go through a lot of different disorders. I'll just run through them, but varicose veins. If you haven't seen that, it's kind of just like oops, I can't type. But you see it on a lot of like the back of people's legs. It's kind of like snake like or tortuous veins. This guy has it really bad. Um, but that happens when you have an issue with your valves, and a lot of times it can get worse, or you can develop it by just like standing a lot. That's why even in clinical they want you to wear like compression stockings so that you don't have pooling, and also like keep kind of moving around a little bit and not sitting, or sorry, not standing. um telectan telangiectasia, sorry, telangiectasia. um it's also called spider veins, but actually, they're a little bit different. But spider veins is basically a type of telangiectasia. Um, they're like varicose veins, but they're like really tiny, and they look like little spiders, basically, or like little. Um, I like to think of them as little like fluff balls or like lightning coming out. But they're usually like really tiny and blue and reddish. DVT, we went through that. Please really ingrain that. That one's most common cause of cardiovascular incidents because it embolizes. It can go to your lungs, your heart, your brain. Um, a key way of identifying this usually is if you see unilateral swelling or edema. And so you're gonna have like two people's legs. Usually it's like um in their legs, right? So one of their legs is gonna be a lot more swollen than the other, probably like red and painful also. And the way we diagnose this is you could use X ray or ultrasound, but the key one that they use is actually a test, called blood test called D dimer, where it tests the amount of fibrin in your blood. That means like it fibrin is used for clots, right? So our clots being broken down and formed all the time. So if you have high D dimer, that means very likely you have a DVT. Aneurysm. I don't think we mentioned that, but you can just generally know what it is. A lot of times, this could be because of, like, for example, atherosclerosis. If you have a plaque on the wall, it kind of like damages the wall and breaks it. Could be because of bacteria. It could be because of hypertension. It could also be just genetic. But you have like a weakening of the wall, and so when blood is pushing through, it starts ballooning out, and this is dangerous because it could rupture anytime, and then you have blood spilling out. A lot of people die from aneurysms. I'm sure you've heard, but if somebody has it in the abdominal aorta, so that'll be like behind your stomach and basically all down your um your abdomen, way in the back. That's your abdominal aorta. If you have one there, that is a medical emergency. Um, and it may also be symptomless, but just because it's just such a big vessel. Arterial dissection is another medical emergency. It's similar to aneurysm, but what happens is that there's like a tear in your wall, um, of your blood vessel. You have like different layers, right? So in between two of the layers, there's like a little tear or something through damage somehow, and then blood starts going there and splitting your walls. Um, that's called like dissecting. So that can cause obstruction, that can cause an embolus, that can also cause rupture, which is all of those are bad. Thoracic outlet syndrome. Um, you have this area right here in your neck, like right above your clavicle. A lot of your cervical nerves and stuff come out right here, like they go through your neck and then they all kind of come out right here, as well as like the big vessels, arteries and veins that feed out to your entire arm. So some people, what happens, because of stress, or maybe they had trauma there, or sometimes people's anatomies are just built different, or sometimes when you work out and stuff, your muscles build wrong, and it can compress all those because, um, just because of the muscles, or like if you have like a narrow outlet or something, and that can be dangerous, of course, because that's all the major vessels that go throughout like your arm, and a lot of through your body too. So it goes through your arms and fingers. Um, I'm just going through. You can just know these like generally, so you know what they are. Raynaud's disease is. You need to know that it's a vasospasm in arteries or arterioles in your fingers, usually in your extremities. It could also be your toes, right? Um, Primary is unknown. Secondary, just know this picture. Um, this is what it's like. It could like they have like bluish tinged fingers. It could also be like white here. It just shows that they're not getting proper circulation down there because of vasospasms. Hypertension. Okay. Hypertension. We already know that hypertension is anything above 120 over 80. There's two different types, primary or essential. This is actually 90%. And that could be anything that are like related to your genetic, age, race, your diet, just like who you are, how you live. Um, it's hypertension because of all these reasons. Again, remember treatment will always be lifestyle changes first. Secondary hypertension is hypertension because you had another problem. You had another condition that got bad, and then that led to hypertension. It's a small difference. I would know this hypertensive crisis. This is also called malignant hypertension. Malignant hypertension is when it goes over like 140 systolic at least, um, or like even higher. Some people have like in 160, 200. That can be it can become a hypertensive emergency, um, because their blood pressure is so high. Small thing that you learn in farm too, hypertensive crisis or emergency, um, has end organ damage. And there's another term you learn that's hypertensive urgency. You'll learn this in form, but that just means like they have high blood pressure and it's concerning, but they don't have end organ damage. When it's an actual emergency and crisis, that means that it's starting to affect your organs. And that is about it, guys. Um, I will try to update this because I really remember writing it, but it's not here. But I'll check my laptop. I'll try to. This is already uploaded. I'll try to update it, and I'll try to upload the video. But I might fall asleep before. But if not, maybe tomorrow morning. But remember, always go through study questions. If you have any questions, just ask me and go through the study questions and quiz questions because I just went through like important concepts, but you also need to know the study questions and quiz questions. Um, I think Mackenzie already had posted here study cues and also her notes here, so you can go through that here. But I'll also put up the individual ones for each chapter in case you want to learn it that way. Yep. All right. Uh, that's about it. If you guys have any issues or questions, feel free to message me. Good luck on the exam, and remember, you're gonna get a curve after, so don't worry about it too much. And good luck. See you
Thank you,
guys.
Nima.
Yeah, thank you.
Thank
Bye.
you.
See ya.